Hello, everybody. This is episode 65 of our podcast, Artificial Intelligence and Cybersurgery. My name's Andrew Gums. I'm here with my co-host. This is the official podcast for our journal, Artificial Intelligence Surgery, the first journal dedicated exclusively to artificial intelligence and surgery. So, Vincent, if you can introduce our guest, which is the first guest that we've had on twice, because he's becoming more than just a guest, but one of our collaborators. But after you, Professor
Sure.
Vincent Grasso of University
Yes.
of New Mexico, please
It's
introduce.
Thanks, Andrew. It's like you said, episode 65, season 3, I believe, right? Which is pretty amazing, and it's a great pleasure to have our friend Karol on. He wears many hats. He's the vice dean of faculty at the at the Medical University of Lublin in the Department of Surgical Oncology. He's doing amazing things in building task forces in robotics and AI and surgery. He's also my I guess my mentor or my supervisor for my PhD candidacy at the Medical University of Lublin. So thank you for that, and welcome back on to our podcast. Karol, could please let our audience know about all the very cool things that you've been doing since the last time you were on the show.
Vincent and Andrew, you guys are too kind. It's such an honor to be part of your amazing podcast again and opening the season 3. We are very thrilled in Lublin and in the entire Poland to have the opportunity to not only watch a site how it used to be in terms of MIS for the past 20 years, but also we have a chance to actually build this new world where robotic surgery, AI, and telemedicine seem to stand proud and tall. So soon, in 2 days, we're meeting in Warsaw. We're meeting in one of the greatest center of robotic surgery at the Military Institute of Medicine, where a consortium will be created and where a national group of robotic surgery, AI, and telemedicine will be introduced. So hopefully we'll be able to apply for grants in both EU and maybe outside Europe as well. Hopefully we will be able to create a national registry of robotic surgery procedures. Hopefully we will be able to gather a data system which will then be able to feed the AI models to perhaps create some new environment where we will be able to enhance our textbook oncological outcomes among patients undergoing robotic assisted surgeries, and hopefully we will find some new solutions for telemedicine, both in terms of perioperative care, but also as it is a military institute that invited us perhaps for some soldiers with PTSD. As we know, the war at Ukraine is still ongoing, so we, as their closest neighbor, are still in the middle of all of it. So hopefully we'll be able to hang into a couple of things and projects.
You know, that reminds me, Vincent, I know you're headed to Lublin shortly. There's a meeting in Ghent called ORSI, the 27th, 28th of February and 1st of March. So before I forget, on your way to Lublin, maybe you can pass through Brussels and we can go together to that meeting. You know, obviously, I hate to put you on the spot there while we're recording this, but I keep forgetting to tell you. So put that in the back of your mind, because it's a great meeting, and it's a meeting with ORSI, which is kind of like a training center similar to EARCAD, but in Belgium. And one of my talks is actually going to be on telemedicine. I'm actually using some of the slides from Dennis Fowler of Sovato, my old mentor. He's the CMO of Sovato, and they've gotten several $1 million to really help with telemedicine, particularly with telemanipulation of robots. And you mentioned the Ukraine. You could imagine that, Ukrainian doctors, maybe even, or Polish doctors operating in Poland could maybe help out, in Ukraine. Who knows,
Yeah, it would be great. I mean, the dynamics and the trends of robotic market in Poland are increasing drastically. As we speak, in 2025, we have 80 systems already implemented, whereas we had around 20, 25 only 3 years ago. So
Wow.
the dynamics are impressive, but at the same time, we recognize the need of structurizing and creating a system that will somehow be able to evaluate it. And then once we reach some feasibility and mastery levels, we'll be able to perhaps help our neighbors. Of course, in Ukraine, I'm not sure if they have one or two robots mainly, but the access is of course limited not only to war but also to various socio-economical factors. So I think that the social vulnerability index in Ukraine is quite high. And as we know, it also impacts the access to MIS and robotic surgery. So hopefully this will be also one of our targets to address, to help our Ukrainian neighbors and patients.
This is a topic that we were talking before we started recording the podcast, but this is a topic that's kind of getting me more and more, I guess concerned is the word, is, you have the desire of companies like Savado to create this ability for telemedicine because of the real ability that there aren't enough surgeons to go around in the world. But then we see the real world problem in Ukraine where there is a war and there are no robots, and you need people who are trained to do surgery. What is going to happen? How are we going to create the next generation of surgeons that still know how to operate? I really have a hard time understanding, especially with the proliferation of telemanipulators. As you know, I'm not a huge fan of telemanipulators. I'm a bigger fan of more collaborative systems where the surgeon and the robotic arms are at the bedside. So how do this is obviously a tough question, Karol, but I'll pose it to both you and Vincent. How do you see the future of maintaining people's capabilities, surgeons' capabilities, but at the same time progressing in the field of robotics?
Vincent, you'd like to start?
Well, I mean, that's a very interesting question. We've talked about the 5 billion people that don't have access to reliable, real-time, consistent surgical care. I would put it out to you guys because you're both full-time practicing. Is can if you don't have the surgical residents getting a lot of hands-on experience, then it's kind of defeats the purpose of almost going through all that training if they're just going to learn robotic and minimally invasive and never really do open procedures. I think that's a big mistake. Having said that, telesurgery is becoming more capable because of the higher speeds going from 5G to 6G, and you'll be able to do a lot more things, but the cost prohibitive buying these massive consoles. So I think there's going to be a shakeup in the industry and with the training. And it's an exciting time also for you guys, right? Because you have surgical residents that you train. What do you think, Karol?
Well, from my point of view and from everyday life, and maybe the cultural and some environment settings in Poland, especially Eastern Poland, is a bit different. But when I first think of telemedicine, modern telemedicine here in Lublin or in the Lublin region, I see a video call to a patient who is discharged home after robotic assisted surgery and post-operative day 4 or 5. He travels around 150 kilometers to his countryside, and he is being told to come to outpatient clinic for a checkup, but we don't know if he's going to make it. So if we'll have a video call with such patient or his family, close relatives, in 7-10 days post-operatively, asking him, hey, sir, how do you feel? We get the patient-reported outcomes. We get the quality of life questionnaire. We can put it into data system. Maybe AI can, record or somehow transcript the voice into text and directly into Excel file. I think it's a great deal, and I agree with Andrew that the bedside surgery is something that we have to focus on, because this advancement in technologies, I believe, can also somehow perish the soft skills that we still require. At least in Poland, people are still afraid, of those AI modern technologies. People think that AI is only ChatGPT. That's it. So it's a huge task for us to explain them what is robotic surgery. That is not actually a robot operating the patient, but it's robotic assisted surgery. And congratulations, Andrew and Vincent, on this new paper in IONS and the nomenclature. I believe that it should be transpired not only to surgeons but to the entire community, because without that, people might get confused at the very early step, and then it will be difficult for us to implement the new technologies, the new concepts in people in society which doesn't even have the basic knowledge about the entire system.
Yeah, thanks for mentioning the consensus conference that we're having on the 12th. I think it's actually Wednesday. So it's just for editorial board members of the journal Artificial Intelligence Surgery, and it's really a planning meeting because I think for us to really get guidelines, we can't just rely on editorial board members. But I want to open it up to people. I don't want to just set up a guideline meeting. I want to open it up to people, at least so we can discuss, think of speakers. So the meeting on the 12th will actually be relative. I'm trying to keep it to an hour or so. We're going to do the in-person meeting in October, I believe. Let me actually check the tentative date. We're going to be doing it with the annual meeting of Women in Surgery in Italy. They're having their 10th anniversary meeting. So we're going to have our meeting the day before on October 17th. They're going to have their meeting on October 18th. So I'm hopeful actually that both of you guys can attend that. I think it'll be great. Obviously, Vincent will probably have to time it when you're going to be maybe doing some work in Lublin, or maybe doing some work for Acrea, because I'm not sure if we'll be able to, being as it'll be our first meeting, I'm not sure how much money we'll have for travel. But yeah, I'm so frustrated with people calling the Da Vinci robotic surgery when it's remote control surgery, and that people still have no idea what a robot is. And I just want to get people, I want people to just remember that a robot is something that replicates the actions of a human. That's all it is. It's not Danger Will Robinson, Danger Will Robinson. You can't get that reference. Karol, you're too young, but I know Vincent gets, what was that, Lost in Space, right, from the 60s?
Yeah, Lost in Space.
Oh man, that was a great TV show. I was just watching reruns myself, but yeah, so we're looking forward to that. But one thing I like to mention is, and Karol, maybe you didn't go through this, but I know Vincent did. When Vincent and I were residents and medical students, we didn't see anything for the first few years. We were retracting, and we were waiting in the operating room for hours, retracting, seeing hands, seeing the back of our surgeons' heads for years. And we were somehow expected to learn. And Vincent, if we think back on that time, what a waste of time. Today's residents, even if they're not doing anything, they're seeing exactly what the surgeon is doing. And like the surgeons today, the residents, they don't know how good they have it. Even if they're not doing anything, they're seeing. There's nothing worse than retracting for 8 hours and not seeing anything but like the back of a surgeon's head, So I'm actually, I always like to remind residents and medical students, it's such a great time to go into surgery, actually. But that brings us to this meeting in Warsaw, Karol. Can you tell us a little bit more about your collaboration with this university, this military university? Can you talk a little bit more about it?
Yeah. So
very excited about it. So are we.
Yeah, with pleasure, and hopefully good things are coming for robotic and remote control surgery in Poland, also in terms of AI and telemedicine we've just discussed. So Military Institute of Health, located in Warsaw, is one of the nationally recognized centers, not only for surgery, but entirely medicine. And nearly 2 months ago, we came up with an initiative to meet up, sign a letter of intent, and to create a national registry of robotic assisted surgery procedures so that we can monitor different specialties. And together with Świętokrzyskie, which means Holy Cross, this is the name of the region in Poland, city of Kielce, not Travis Kielce, go Eagles, by the way, on Monday.
Oh, is that how that's pronounced? It's pronounced Kelsa?
Kielce, yeah.
Oh, we say Kelsey. Oh, it's Kelsa. Oh, great.
Kielce,
Polish.
yeah.
Oh, I didn't know
Yeah.
that. Great.
Well, you just he's Kelce, and we add I between K and E, so that's the only minor difference. Yeah, but anyway, the idea is to somehow monitor and evaluate the trends we discussed. So if we have already 80 robots, and if there's one robotic system for approximately 470 100,000 inhabitants in Poland, you need to have some sort of structurized training. What you just mentioned about residents being able to see the procedure is, of course, priceless. But we, as attendings, we have to take them into the next step. The average age of surgeon in Poland is around 60 or even 61 this year. So if we won't wake up soon, we won't have surgeons to operate us. Of course, we are discussing the problems of the need for conversion from MIS to open. A lot of surgeons haven't seen a open procedure in years. In Poland, this might not be actually that much of a issue as it is, for instance, in the Netherlands, because we have to remember the times of communism, and we have to remember that Poland, despite its economical growth, we are still approximately a decade, 15 years behind in terms of some systemic solutions.
But you still have problems of residents probably not knowing how to do open cholecystectomy, right? Or is that still routinely done in Poland?
No. Yeah, cholecystectomy, and even the major breakthrough was in appendectomy. Sometimes we have work migration, and we work in different places, different units. What's I think good that we experience is the fact that even in those small community hospitals, surgeons are performing acute appendectomies with a laparoscope instead of open method. So that's good. There's an increase in terms of different specialties which are utilizing Da Vinci or CMR. So Warsaw Military Institute, they have 10 specialties in terms of Da Vinci. And what's good about those guys is the fact that from a national scale, still around 75% of all robotic assisted procedures are reserved for urology, whereas in the military institute it's only around 25%. So there's a lot of colectomies, a lot of gastrectomies. They invite guys from the Netherlands. They had Jelle Jurda from Utrecht performing one of the first robotic esophagectomies in Poland. They're very skilled in cardiac surgery, skilled in thyroid robotic assisted procedures as well. They introduced bariatrics, I think in December. So it's definitely a institute that can be this giant that will stand on shoulders and trying to see further, as Newton would say.
So Karol, was that from Newton, standing on the shoulders of giants?
Yeah, actually, I was there's a paper I'm always quoting in every single lecture, published in Annals in 2023, I believe. Evaluation of over 600 robotic Whipples from various centers, and the University of Pittsburgh being as this pioneer high volume center, showing that different high volume institutions like in Amsterdam or Rotterdam can implement and master a robotic Whipple quicker than the Pittsburgh did. So the thing with the standing on the shoulders of giant, because that's how the paper is entitled, is the fact that Newton wrote this in a letter to Robert Hooke, his huge rival, but he was actually making fun of him because Hooke has this famous huge thoracic kyphosis. So Newton was kind of making fun of him that he looks like somehow was as a midget. But actually, the whole standing on the shoulders of giant comes from actually France, I think. Charles Leclerc, 12th century, he was a Neoplatonist. And also, you have Umberto Eco and Name of the Rose. Also, they mentioned standing on the shoulders of giants. Apollo 17 mission, their title was standing on the shoulders of giants as well. So it's like the whole concept of philosophy. So you're trying to overcome what's already being evaluated, experienced, or discovered, and you're just trying to get more from your mentors and from your proceedings.
Yeah. So Sir Isaac, I just did Chat GPT, and it's
Oh,
Sir Isaac Newton, in the letter he wrote to Robert Hooke, I have seen further, it is by standing on the shoulders of giants. However, the concept predates Newton, back to Bernard of Chartres. We are like dwarves sitting on the shoulders of giants. We see more and farther than they, not because of our own vision, but because we are lifted up to their great height. Love it. ChatGPT also. Two things. Number one, what is the most famous Polish athlete in America, in the United States? Is it or is it not? Is it or is it
Robert
not?
Lewandowski?
No, is it or is it not Wayne Gretzky? And if it is not Wayne Gretzky, why not?
No, I don't think it's Wayne Gretzky.
You're too young. You're too young. So who'd you say the most famous one is?
But I mean, you like living in US or
a Polish American or a Canadian American. Who's the most famous?
Like from our perspective, and you mentioned hockey, and I obviously know who and Gretzky. We had those two hockey players. Maybe Vincent would know one, Krzysztof Oliwa from New Jersey Devils, and the second one was Mariusz Czerkawski from New York Islanders. But just to mention one most famous, it's hard to think of one. I think that everyone in America knows who Robert Lewandowski is, obviously. But in mentioning a Polish American athlete, probably Wayne Gretzky, as you said.
Okay. And my next question: the military hospital in Poland, in America, military hospital, they only operate on military personnel. So in China, I'm not actually, I think it's similar, but I'm not sure. What is it like in Poland? So when I hear military, I think you're only taking care of soldiers and families of soldiers. What's the difference in Poland?
We have public health system in Poland, which means that in case of military institutes, they also take care of all the patients that would come to ER or are elected for some procedures or admitted to different units. But in terms of any military actions, they are in control. For instance, if a president of United States would pay a visit to Poland, they would be the one that would take care of the entire health system. They would work it out with the US military forces prior to landing of POTUS. So they have their own system. They have their own network of military hospitals, with Warsaw being the centered one. But at the same time, they are also performing, let's say, commercial healthcare services. Also, one more difference is that if you want to become a surgeon in Poland, of course, you have to take the national board exam. And there is this central list being developed by the Ministry of Health. Whereas if you would like to become a surgeon in the military institute, they have their own list or they have their own application system, which is derived from the Department of National Security.
So Vincent, how do you see us working with this institution? Sounds like Karol has really set us up well. What are your thoughts? How to move forward?
Well, I think, from the perspective of surgical robotics, you have, very deep expertise in that. We collectively have deep expertise in all things telemedicine, whether it's the designing of systems, integrating telecommunication platforms, data security, that's our wheelhouse. And when you combine those components, I think we can be very helpful with strategy and design and collaboration and advancing our mentorship program to getting our surgical residents involved in these this innovation that they generally wouldn't get exposed to. So, Karol, if that's helpful for you, we can bring a lot to the table to help you with your program and expansion.
Definitely. Our thoughts after working with 3 robotic systems after CMR, Da Vinci, and Acrea. My personal belief is that no individual expert, even world class, will overcome the needs for creating a system for training, evaluation, and then expanding it to further, as it would be in terms of a national group or consortium. So definitely with your experience, I believe that you would be a great asset, both you and Andrew, in terms of providing us with some feedback and also thoughts on how the next steps should look like in terms of implementing solutions that would be beneficial not only for individual but for the entire community.
So do you have any idea about how many surgical hospitals there are in Poland? If you had to guess about how many? I know that's a tough question. I guess I should ask ChatGPT while I'm here.
Yeah, we can compare, right? Well, the thing is that only in Lublin region, I would say that among 30 hospitals, only in the last 3 or 4 months, at least 4 were shut down. So we have a huge problems with that.
Wait, what do you mean shut down? Hospitals were shut down?
The general surgery units were shut down.
Why? Explain.
We have 2 major issues. One is the aging of surgeons, previously mentioned, and the second one is the actual access to anesthesiologists. Lots of anesthesiologists are working also as part of the fragmentation of work. So this is what we usually do in Poland. So you can work in an academic center from 8 to 2 p.m. and then you travel 50, sometimes 100 kilometers to a remote hospital or community hospital, and you have a call there until 8 in the morning or 6 in the morning, and then you travel back to your institution. And you work in those remote hospitals as a contract worker. So the salary is way more higher than it is as a regular pension back in the academic or a city hospital. But no one asks you like, hey man, like you've worked for 3 days straight. Aren't you tired? Like, shouldn't you rest a bit?
Oh,
no
wow.
one is checking.
In France, if you're on call and you operate the next day and you have a problem with a patient, you are not covered. You're not covered, which I think is a good thing for many. But the way people get around it is instead of taking call, they do what's called an estrant, where like you're at home taking calls. That, even if you operate all night, but you are legally not sleeping in the hospital, the next day you can operate. So that's the way they get around it. That doesn't exist in Poland. Well, in Poland, it doesn't matter whether you're on call or you're at home or in the hospital. You can still work the next day.
I'm not supposed to say that. Like, no one's checking, man.
No, it's a big problem. I mean, with all the studies that show.
This is also the why we are putting up this initiative. So we believe that if we create some systems, we can actually make the whole surgical field more excellent in different aspects, such as the night calls, night shifts as well.
Yeah, no, it's a big problem. So, okay, it looks like we have 10 minutes left, guys. Actually, it's a big problem with call. I don't know how to fix that. But in Poland, do you have private practice or not? Do you have pure private practice?
We do have private practice, but it's usually limited to private outpatient clinics. So
Right.
what people do usually, they get some symptoms, let's say, bleeding from the um, GI tract. They see some blood on the stool, and they immediately freak out. Sometimes they would go to their GP. The GP would send them for colonoscopy, or at least for taking some lab results, lab checkup. But what patients do is they immediately Google, find me an oncologist, find me a surgical oncologist. Okay, who's this guy? Okay, he's you can get an appointment for 100 euros in 3 days. Okay, let's do it. And that's usually in the private outpatient clinic. And I don't know the exact numbers, but roughly I think that perhaps 50 or even 60% of patients would start from this private route, thinking that, okay, if I'll pay for a visit to a doctor, he'll take better care of me. And then, but what usually is happening, there are no, or very limited, private surgical hospitals. uh, Actually, urologists, they have 2 or 3 private urological hospitals where you can pay, I don't know, roughly 8-9 thousand euros for a robotic prostatectomy. But this doesn't concern the abdominal surgery or other cancer surgery. So the thing is that after getting this checkup, some imaging, patient is still being admitted to a public hospital, where we do have some solutions like oncology card. And once patient is having this oncological card, he expects to have a CT scan or MRI within 2 weeks. If there's a staging laparoscopy necessary, he should get it within next 2 weeks. So the idea of this oncological card is to enhance the beginning of treatment, whether it's upfront surgery, as it is for, let's say, colon, or is it neoadjuvant, as for gastric, or I don't know, rectal, and neoadjuvant radio chemotherapy. The idea is to start the treatment as quick as and feasible as possible if the patient is in good general condition. And then after the surgery, also the patient is being follow up in this, let's say, somewhat organized manner, that he definitely will have a spot at the public outpatient clinic within 30 days after surgery, more like something like that.
So, Vincent, this is reminding me a little bit of that announcement. I think it was called Stargate, where Sam Altman, I believe, of OpenAI, made an announcement with Trump that they're going to put a $500 billion of investment, and then there was debates of whether they really raised the money or not. But essentially, there's a huge interest in governments to utilize AI to really connect all the hospitals, to connect all the data. I mean, just listening to Karol, I'm thinking about people going to all the private clinic and then coming into the university and then getting their MRI and then getting their colonoscopy somewhere else. And then, all the information scattered all over the place. Your patient comes to you with some printed piece of paper. It's a mess. Then you scan it, you put it in your system. And as we all know, it's just it's chaos. It really is just chaos. We spend most of our time consolidating all the data per patient, and the surgery itself takes what, 5% of, if we think about all the time we take care of taking patients, making rounds, consults, seeing them in follow-up, sitting in tumor boards, reading their charts. The surgery itself is 5% of what we do, right? I mean, it's terrible. That said, do you think? Well, okay, so that before we get to that question, we saw that China released DeepSeek last week, and we saw that the shares in technology companies in the United States dropped $600 billion. So Vincent, this is a big question, but I love giving you the big questions at the end. Do you think the time is now right for $500 billion to be invested in this in the United States? Do you think China is going to be able to come up with a solution that's much cheaper? What are your thoughts on? It's a real lot of things are shifting in this space. So, what are you able to do? What's our future looking like? Should we try to do something like this in Poland? Should we try to connect the hospital? Should that be our main task?
That's a good question, and what we've realized is that a simple announcement from China about a competitive and innovative platform nearly resulted in $1 trillion of market change. That means that there's profound uncertainty in the market. People don't really understand this stuff. It's complicated. People that don't invest time in learning about it are dependent upon what they read online. But what's going to happen, and why this is so exciting for Karol, is if you were in an organization that 10 years ago invested a lot of money in building technology, you may now have the opportunity to rewrite the whole thing at a very low cost. So when you're starting from scratch in 2025 and you bring the right people on board to take advantage of the new technologies that exist, and you make the right investments, you may wind up with a profoundly powerful and less expensive system. And that's the beauty of being, involved like us in 2025 with these exciting technologies. We're not stuck with having to use things that were developed 10 years ago, which were very expensive, using old technology and old insights, old architecture. And you can move pretty fast now, as you see using, Andrew, a generative AI platform that you're playing around with. 6 months ago, you're very different than you are now. You're leveraging that technology, but I'd like to just bring this important point. The danger is that when you have people that don't have domain expertise using those systems, not vetting the answers, not vetting it, and assuming that it's all correct. Look at your training and background. So when you get an answer from ChatGPT or Google Gemini, you have an understanding already if it makes sense or not, and whether you'll use it or not, right? So that's why it still requires a lot of training and education to take advantage of these systems. But I think it's going to be much more than $500 billion will be spent. Many trillions of dollars will be spent, because now it's a race to who gets the best technology and has the competitive advantage. But Karol's in the middle of this innovation in Poland, and it's very exciting to pick the best tools that he has access to and the right people, right? That's what you need, the right people and the right tools, and you generally succeed.
Well, looks like we have just over a minute left. So Vincent, that was a great synthesis of what's going on. Why don't you close this out, and I'll say goodbye to Karol.
Well, it's great.
Thank you so much for another episode. 65 was a pleasure as always, and I'm looking so much forward to our future meetings. Thank you.